Namaskar, dosto. Good evening, friends. I am Dr. Sanjay Kalra, your friendly and familiar endocrinologist, and you are watching Obesity Special Med Talks with Dr. Sanjay Kalra. आज के हमारे नॉन स्टॉप शो का 1059वां 1059th एपिसोड है. Let's have the headlines for the day. The drug tirzepatide has demonstrated not only long-term weight reduction, but also diabetes risk reduction in people living with obesity. इसका मतलब ये जो दवा हम देते हैं उन लोगों को जो मोटापे के साथ रहते हैं उनका शुगर होने का, डायबिटीज होने का भी रिस्क कम होता है. Of course, the same drug is used for management of diabetes as well. So this means it can be used for both management and prevention of diabetes. And other research has found that this drug is effective for weight loss, regardless of the number of obesity-associated diseases that the person has. तो जितनी मर्जी complications हो obesity की, ये दवाई असर करती है. Now, interesting research and researchers have found that hydrogen sulfide can be used as a treatment for obesity. अब हाइड्रोजन सल्फाइड तो गैस है और बदबूदार भी है काफी, तो अब इससे वेट कैसे कम करता होता है, वी नीड टू फाइंड आउट. मे बी आवर स्पीकर विल टेल अस. एंड एट द सेम टाइम इंटेंसिव लाइफस्टाइल थेरेपी, अब इंटेंसिव मतलब खूब जोर से, इंटेंसिव लाइफस्टाइल थेरेपी is considerably more effective for weight loss than brief advice from a healthcare professional. तो जब आप अपने डॉक्टर के पास जाते हैं, वो आपसे बात तो करते हैं, मगर उस अकेले बात से कुछ बात नहीं बनने वाली. You need to be very intensive in terms of behavioral management. And research that has led to the development of obesity drugs is getting prizes all across the world. अगर इतने सारे प्राइज मिल रहे हैं ओबेसिटी वाली दवाओं को और इतनी सारी दवाएं आ रही हैं मार्केट में, तो इनके बारे में हमें जानना चाहिए. So let's see what our topic is for today. Recent medical advances in obesity. Okay, so recent medical advances in obesity. So if we need this topic to be discussed, then we need an expert in obesity, that's an endocrinologist. We need someone who is up to date with the recent advances, and that would be someone who is a perfect blend of wisdom and youth. So warm welcome to Dr. Vishnu Radhakrishnan.
Thank you, sir. Thanks for the kind words of introduction.
Thank you, Dr. Vishnu. And Dr. Vishnu का नाम भी जो है Vishnu and Radha and Krishnan, that is a perfect blend of everything good on the world. So everything nice and naughty perhaps is what Dr. Vishnu is. But formal introduction, Dr. Vishnu is a highly skilled endocrinologist working at KIMS Health Al Shifa Super Specialty Hospital in Kerala, in Perinthal, and he has extensive expertise in managing complex endocrine disorders, including diabetes and obesity. His main focus is person-centered care. So person-centered care means keeping the person in front of you at the center of everything that you do. It also means offering the best possible in the world to your patient. And your patient should have a choice of various things to choose from. So, Dr. Vishnu, how does it feel? You've worked in all parts of the country, from the extreme north now to the extreme south. This concept of person-centered care, is it the same across the world or is it different from place to place?
It is actually different because now actually I am practicing in Malabar area, but where I did my training is in at AIMS Rishikesh, where people are of Pahadi people, and they usually walk a lot all the day. But in Kerala, the things are different. People eat a lot and they walk less. So the spectrum of people and the spectrum of diseases and the spectrum of total lifestyle diseases, what I see is different. So the thing, whatever, entirely the cultural difference is also there all across the India. So whenever we advise a lifestyle intervention or a diet advice, which has to be followed, the compliance of the thing is very important. So we have to advise in a patient-centered or a patient-centered manner for a long-term compliance of both the lifestyle as well as drugs. So this differences has to be kept in mind before prescribing something or prescribing some lifestyle things for those patients.
So thanks, Dr. Vishnu, for that. With this, would you like to discuss the various advances that we have now in medical therapy of obesity? Meanwhile, we have people logged in from across the country. Swapna Jainji from Vellore in Tamil Nadu, wishing you a good evening. Rana Ali is saying hi to you. And also Ramchandra Joshi, thanking you for keeping this this effort of the late Dr. K.K. Agarwal going ahead. So carry on, Dr. Vishnu. The floor is
Yeah,
yours.
yeah, we can continue to have the presentation on screen then. My slides are visible, right, sir? Hope my slides are visible. Can you start? So today I'll be discussing with the medical management of obesity, the recent advances. So why to go with medicines for the management of obesity? That is a thing of concern. So I'll be outlining the things in breaking down the subject in introduction, pathogens of obesity, anti-obesity medications, which are FDA approved, and newer agents in the armamentarium and research therapies. And I would like to go with my experiences with obesity drugs, trials, and all. So, regarding the introduction, obesity is a state of excess adipose tissue mass. Forget about BMI. Obesity is not about BMI nowadays. So, the newer terminology for obesity is adiposity-based chronic diseases. And obesity is defined by American College of Bariatric Physicians by the definition of absolute fat content in the body. That is, fat percentage more than 30 in females and fat percentage more than 25 in males. That is obesity. So it is a separate disease entity rather than a mere risk factor for cardiometabolic diseases. So we should address obesity like that. It's a chronic condition with an initial progressive weight gain which is followed by a plateau. So it is a relapsing condition. So weight regain occurs even after weight loss with lifestyle measures and even after bariatric surgery. So short-term treatments do not change the underlying biology driving or maintaining the condition of obesity. So there was an earlier term which is called metabolically healthy obesity, which is totally obsolete and misleading now. So if you are obese, it is an independent risk factor for both morbidity and CV mortality. And there is a long-term follow-up higher risk of CV events in case of metabolically healthy obesity as compared to metabolically healthy non-obese individuals. So eating for pleasure. So food is always food centers are hedonic centers. So eating for pleasure is the major contributor for exogenous obesity or obesity due to overeating. So there are many complex areas in the hypothalamus which controls the appetite as well as satiety. So there are orexigenic peptide, there are anorexigenic peptide, which brings down the appetite. And there are many pathways, satisfying pathways or hedonic pathways in the brain, including dopaminergic pathways and serotonergic pathways, which are dually satisfied with the food that we take. So this is one of the major contributors for exogenous obesity. So BMI is not the ideal measure of Indian phenotype obesity. That is clear from many studies. So we have the ICMR India data by Anjana Mohan et al., which has come last year. So the prevalence of BMI when we take the prevalence of obesity when we take a BMI cutoff of 25 is 28.6. But when we consider abdominal obesity or waist circumference as a surrogate of visceral fat or obesity, the amount of obese individuals are coming up to 40%. Okay, we can actually observe a stark difference in between the BMI cutoff, the percentage as we get from the BMI cutoff and the waist circumference cutoff. So it is very important to go with the absolute fat content rather than merely looking at the BMI. And again, we have a data from National Family Health Survey from 2019 to 2021. So here it is pretty clear that abdominal obesity is seen in normal weight individuals. So it is actually seen in almost half the patients with normal weight and almost one third of the patients with underweight. And obviously it is higher in overweight and obese individuals. But the point is that even people with normal weight and people with underweight are having abdominal obesity. They are also not metabolically that much healthy as we think. So obesity-related complications, there are empty number of obesity-related complications, which are starting from mental disorders, that is attention deficit disorders, depression, anxiety, panic attacks, various malignancies like CA colon, CA breast, and CA pancreas, various cardiovascular events like atherosclerotic cardiovascular disease, hypertension, AF, heart failure, and various metabolic issues like type 2 diabetes, fatty liver disease, dyslipidemia, gallstones and gout, and coagulopathy, skin issues, reproductive issues, both in males and females, musculoskeletal issues, pulmonary issues, and urogenital issues. So both environmental as well as genetic factors can contribute. So for an individual, food is the sole source of energy intake, whereas energy expenditure can be from okay, it can be divided into various parts, where basal metabolic rate or resting metabolic rate is a major portion, followed by thermogenesis, which can be induced by food intake, and physical activity, which can be divided into exercise as well as NEAT, that is non-exercise activity thermogenesis. So this is a portion of energy that is spent for our posture maintenance and all, which is spent unknowingly by us. And there are several genes which are involved in the orexigenic or anorexigenic pathway, which also causes a reason for obesity. So, regarding lifestyle modifications, so weight regain is too common after lifestyle interventions. So we have the famous look ahead study with in front of us, where with the intensive lifestyle interventions, the patients lost almost 8.5 percentage of their initial body weight by the end of 1 year. Later, they almost regained half the weight over a follow-up period of 8 years. So again, diabetes prevention program outcome study, which was published in Lancet in 2009, also showed the same pattern, where with lifestyle interventions, where patients were having a fixed aerobic exercise per week along with a hypercaloric diet. Again, the initial weight loss was there, which was followed by a later gain of weight in the later years. So weight regain is inevitable with lifestyle interventions. So, what are the causes for the weight regaining or the failure of lifestyle interventions in the management of obesity? So, hormonal adaptations plays a major role. So, we can see in a follow-up study, weight is going down, and over the time, weight is coming up. So the same thing, the same graph, the graph of hunger also parallels with the same. Hunger is actually going down initially, and later at a lower weight, the hunger is going up, and patients starts taking more. So during the postprandial time, over a period of time, the orexigenic hormones like ghrelin and peptide YY is coming up and plateaus. Whereas other hormones, anorexigenic hormones or protective hormones from obesity like amylin and cholecystokinin is peaking after a period and it is coming down, which causes increased increased feeding or increased hunger. So this is a meta-analysis which actually showed a compensatory decrease in energy expenditure over a period of time after weight loss. So energy, the ability of the body to lose energy is also coming down after a period of time. So which is also shown here. So increased cortisol level following a weight loss, it is another theory. So if we are asking a patient to restrict calories, so the patient has to resist the temptation to take a lot of food. There is an act of monitoring calories over the time while on diet plan has shown to increase the perceived stress. So the increase in serum cortisol has not been consistently shown in all the studies. So the evidence is not that robust, but still there is an element of increased stress. So there is an element of increased cortisol, which can again cause a regain of weight. So why people living with obesity need pharmacotherapy? Then is another question. Obesity is always a progressive disease. It is centered upon brain. So it is influenced by complex interaction between inherited factors as well as environmental factors. So weight loss achieved with diet, physical activity, and behavioral modifications are limited. It is always difficult to maintain. So maintenance of weight loss is challenging due to metabolic adaptations of the body. So pharmacotherapies that combine weight loss efficacy, long-term safety, weight loss maintenance, which reduces the complications, are really needed. So FDA has got some criteria for anti-obesity drugs to get approved. So these guidelines were issued in mid 1990s. So the new drug for coming into market should have a statistically significant weight loss of more than 5% at 1 year, or at least should cause weight loss in more than 35 percentage of individuals with an minimum weight loss of more than 5%, which should be at least twice that of the weight loss which is induced by the placebo arm. So in addition, the medication is required to show evidence of improvement in metabolic biomarkers, including blood pressure, lipid levels, and glycemic control. So medical treatment of obesity, what are the principles? So anti-obesity medications affect the pathophysiological pathways that lead to obesity, and treatment affects both weight and comorbidities. And we should always counsel the patient, and as physicians or endocrinologists, we should also expect a heterogeneity in the weight loss response. Not every patient is not going to lose weight with these medications, and duration of treatment, that is also again a problem. So theoretically, the patient has to receive these medications lifelong for maintaining the weight loss. The moment you stop those medications, there is high tendency that these patients are going to regain the weight that is lost with the medications. So we should be aware about these things also. Probably in our clinical practice, it's a difficult thing to say to tell patients that they are going to be on these medications for their entire lifetime. So our clinical judgment again plays a role here. So we have ESA guidelines of 2015 in front of us, where an individual with weight more than 20, BMI more than 27 with comorbidities are candidates for pharmacotherapy, and individuals with a weight more than 30 even without comorbidities are a candidate for pharmacotherapy. We have similar cutoffs of 40, 35 and 40 of BMI, kilogram per meter square, for bariatric surgery. So, what are the FDA approved anti obesity medications that are available in the market? We have the Ejol medication, Orlistat. We have phendiramine, topiramate, naltrexone, bupropion, and among GLP agonists, the gut molecules, we have liraglutide or Victoza, or we have a brand called Lirafit now, and injection semaglutide 2.4 milligram once a week, or Wegovy. It is not Ozempic, it is Wegovy. So we have dual receptor agonist, GLP, GAP dual receptor agonist, tirzepatide. That is the latest one which was approved last year. So regarding the FDA approved drugs, we have Orlistat, which is a gastrointestinal and pancreatic lipase inhibitor, and Sandoz was a trial which actually tested the efficacy of the drug. The FDA approved dose is 120 milligram TDS orally, but many of the physicians and endos are actually giving it at an over-the-counter dose of 60 milligram TDS. So the mean placebo-subtracted weight loss is pretty low, 3%, and it has got a lot of gastrointestinal side effects like bloating, flatulence, oily, stools, fecal urgency, etc. So again, we have phendiramine, topiramate. Phendiramine is a centrally acting sympathomimetic, so it can increase the energy expenditure, and topiramate is a GABA agonist, which has got glutamate antagonistic as well as carbonic anhydrase inhibitor property. So it can actually induce satiety by reducing the appetite. So the maximum dose is 15 milligram per 92 milligram, and the trials were Concur and Sequel, which actually showed a placebo-adjusted weight loss of 6 to 7 percentage, and it has got actually anticholinergic symptoms, other adverse effects, dry mouth, insomnia, dizziness, palpitations, etc. So we have naltrexone and bupropion, which is an opioid receptor antagonist, which was combined with a dopaminergic drug. So the dose was 16 and 180 milligram, and CORE2 trial actually demonstrated a placebo-adjusted weight loss of 5.2%. Anticholinergic side effects are very common, nausea and dry mouth. So again, the interesting class of drugs are gut peptides. So anti-obesity drugs predominantly acting through GI system. So we have single agonists. So GLP-1 receptor agonists, amylin analogs, peptide YY agonists, which are actually coming up, and dual agonists, that is a synthetic GLP and GAP receptor agonists like tirzepatide, and GLP and glucagon receptor agonists like survodutide and all, and GLP-1 receptor and amylin combination drugs like CagriSema and all, where the trials are actually going on. And we have a newer drug, which is a triple agonist, which has got an agonistic property at all the three receptors, that is GLP, GAP, and glucagon. And that drug is called retatrutide, where it has shown almost 26 to 30% weight loss. So almost 1/3 of the weight is lost with the drug in the trials. So regarding the GLP receptor 1 agonists, which are in our clinical practice, we usually commonly use liraglutide, which can be given as a subcutaneous injection, and we have semaglutide, only subcutaneous forms of semaglutide, that is Wegovy, 2.4 milligram subcutaneous weekly is actually approved for the treatment of obesity by FDA. In India, we don't have subcutaneous forms. We have only oral forms, which are called Rybelsus, which are actually FDA approved for diabetes, but still we are actually, some of the endos and physicians are using it for treatment of obesity in an over-the-counter manner. So what are the mechanisms? We actually very well know the mechanisms of actions of GLP-1 receptor agonists. So in the liver, it can actually bring down the gluconeogenesis and it can decrease steatosis. So it has got some role in MASLD. In many studies, lean trial was there in front of us. So it is actually bringing down the weight. This actually it can actually reverse the stages of NASH. But there is no proven effect on fibrosis. That is another thing. Again, on intestine, it can actually decrease gastric emptying. It can decrease gastrointestinal motility, hence it is contraindicated in gastroparesis. And brain actually it can actually affect the brain centers to decrease the food intake, and it can decrease the reward behavior. So we should be very cautious whenever we give these drugs to patients with depression. So there are many studies which shows that semaglutide has got a tendency to increase suicidal ideation in some of the individuals. So muscle, it can increase the insulin sensitivity, it can increase the glucose uptake. So in pancreas, it can increase the glucose secretion, increase the insulin, it can increase the insulin secretion, which is actually glucose dependent. So it can increase insulin synthesis, it can increase decrease glucagon secretion, and decrease the apoptosis of beta cells. So theoretically, the insulin secretion by these drugs are sugar dependent or blood glucose dependent. So theoretically, they should not cause hypoglycemia. But still, there are case reports where liraglutide, even in our clinical practice, there are patients who are developing hypoglycemia with liraglutide sub-Q preparation. So I'll be just rushing through the studies of liraglutide. We have scale trials. Scale obesity trial were actually conducted in obese and overweight patients, where they actually followed up the patients for 56 weeks, and a placebo-adjusted weight loss was 5.4% for the drug. The scale obesity and pre-diabetes extension trial, they actually took a subgroup from the scale obesity trial. Those patients with pre-diabetes were actually followed for 160 weeks, and the placebo-adjusted weight loss was 4.3%. And scale maintenance was for overweight or obese patients who actually lost more than 5% of initial body weight in the 12 weeks running period with low calorie diet. And such patients were actually followed, that subset is assessed for over a period of 56 weeks, and the placebo adjusted weight loss was 6.1%. And again, the last one was scale IBT, that is intensive behavioral therapy, where patients were actually instructed to be given hypercaloric diet along with a fixed exercise in between 150 to 250 minutes per week. And such patients were followed for 56 weeks, and the placebo adjusted weight loss was 3.4%. So parallel semaglutide or Wegovy, the trials were step trials. So obese individuals or overweight individuals, more than one comorbidities were taken. So over a period of 68 weeks, the placebo-adjusted weight loss was 12.4%. Step 2 trial, overweight with type 2 diabetes were taken. So the placebo-adjusted weight loss with the maximum dose was 6.2%. And again, step 3 trial was with parallel semaglutide with IBT combined with intensive behavioral therapy. Here, actually, the placebo-adjusted weight loss was 10.3%, which was pretty high as compared to the previous drug, scale IBT, liraglutide. So again, sustained trials come. So sustained trials were the CVOT trials for the diabetic dose of the same drug, subcutaneous dose. So these were the CVOT trials for Ozempic or subcutaneous semaglutide, 0.5 to 1%. So the results, the weight loss of sustained 1 to 5 were actually shown here. So as compared to placebo, there was a progressive decline, which was statistically significant in the weight in the both groups, 0.5 as well as 1 milligram of sub-Q Ozempic, which was given weekly. So after this results, they actually went ahead with higher dose, the step trials and all. So again, tirzepatide, it's a once weekly subcutaneous injectable peptide approved by FDA for type 2 diabetes and obesity without type 2 diabetes. Type 2 diabetes and obesity without type 2 diabetes. It is engineered from a native GAP sequence with an agonistic activity at both GAP and GLP peptides. So it has an action which is similar to other GLP-1 analogs. So the trials for obesity were called SURMOUNT trials. So SURMOUNT 1 trial, obese or overweight individuals for more than one weight-related comorbidities without diabetes were chosen, and they were actually followed up for a period of 72 weeks. The placebo-adjusted weight loss for the maximum dose was 17.8%, which was very significant. So SURMOUNT 2, again, obese individuals with overweight or obese individuals with type 2 diabetes. were chosen, and over 72 weeks, the placebo-adjusted weight loss was 11.6%. And in SURMOUNT-3 trial, obese individuals or overweight individuals with more than one weight-related comorbidities were actually followed up. So, those patients who showed a more than 5% reduction with 12-week IBT in the running period were actually followed for 72 weeks, and the placebo-adjusted weight loss was 20.8%. So anti-obesity medications on trial. So oral GLP-1 receptor agonist semaglutide has completed phase 3 trial, and we have oral GLP receptor agonist, which is a non-peptide molecule, that is orforglipron, is also has completed phase 2 trials along with danuglipron, and other molecules like GLP-1 plus glucagon dual receptor agonists are there, which are, the examples are survodutide and pemvidutide. And GLP-1, GIP, and glucagon triple receptor agonist. As I told, the compound's name is retatrutide, which will come up. And amylin receptor analog is called cagrilintide, which can be given as a once weekly preparation. And cagrilintide combined with semaglutide, that has made into a combination called CagriSema, which is actually undergoing a phase 3 trial now. So a few words about oral semaglutide, which is widely available in India under the brand name Rybelsus. It is actually brought by Novo Nordics. So this is semaglutide is a peptide. So it is always for a peptide molecule, it can get degraded within the stomach and intestine. So the site of absorption for the peptide semaglutide is stomach. So peptidases can actually disrupt the molecule. So for avoiding the disruption of the molecule and enhancing the absorption of this molecule, a compound called SNAC, that is sodium N-aminocaprylate, is combined with this molecule. So that's why this peptide is getting absorbed to the bloodstream. So again, we have this molecule in 3 milligram, 7 milligram, and 14 milligram. So probably we can actually start with 3 milligram, and 7 and 14 milligrams are the maintenance dose of the molecule. So we have pioneer trials, which are the CVOT trials for Rybelsus or oral semaglutide. So again, it has shown a statistically significant, all the pioneer trials over 26 weeks, 52 weeks, and 78 weeks have shown a statistically significant weight loss over a period of time with 3%, 7%, and 14% semaglutide as compared to placebo. Then actually they did a trial, Pioneer Plus, where they actually tried increased doses of semaglutide, which are not, which are actually the superior doses as compared to the anti-diabetic doses. They actually tried the drug in 25 milligram, and they tried the drug in 50 milligram. So with that, the 25 milligram and 50 milligram has actually shown a very significant weight loss, that is almost 6.7% and 8%, as compared to 4.4% with the 14 milligram tablet over a fixed period of time of 52 weeks. Then actually they came up with a trial, obesity trial, standard obesity trial of oral semaglutide. That is, they actually did it with the dose 50 milligram of oral semaglutide or Rybelsus. So it was a randomized double-blind placebo-controlled study. So they chose the patients who has indications for the drug without any diabetes. And the primary endpoint was the percentage change in the body weight, and whether participants reached a body weight reduction of at least 5% at 68 weeks. They looked at the same. So as compared to placebo, in the comparison of oral semaglutide 50 milligram, almost 85% of the patients lost more than 5% weight, and almost 1/3 of the patient lost more than 20% of weight, which is very significant. So we have newer molecules like dual agonists for GLP and other gut hormones such as glucagon or GLP are coming up. So glucagon can increase energy expenditure and increases the fat oxidation. So that is the main mechanism by using glucagon agonistic property in such drugs. And GLP can promote fat accumulation in subcutaneous white adipose tissue and has no appetite suppressant effects. So we have the new molecule that is a triple agonist. GIP, GLP, and glucagon receptors are stimulated by the molecule retatrutide. So it's a single peptide conjugated to fatty diacid moiety. Agonism towards GIP, GLP, and glucagon receptors are there. It is more potent at GIP receptors, less potent at glucagon and GLP receptors. So half-life is 6 days. So that enables a weekly administration of the drug. So the retatrutide phase 2 trial, so it is randomly assigned at various concentrations of the drug subcutaneously once weekly, given for 48 weeks. Primary endpoint was percentage change in the weight from the baseline, and adverse effects were highest with the highest weight dose of the drug, that is 8 milligram and 12 milligram groups. So we can clearly see as we go up with the doses, the weight loss is also there. More than 30% weight loss is actually seen in almost one third of the patients, 26 patients with the maximum dose of the drug. So almost in almost one fourth of the patients, these patients are actually losing at least one third of the weight over a fixed period of 48 weeks. So this drug is going to be a game changer. So we have orforglipron, that is the non-peptide counterpart of oral semaglutide or Rybelsus. So it is a once daily molecule, oral non-peptide GLP-1 receptor agonist. It has got some a smaller size and it is better absorbed because it's a non-peptide molecules. The bioavailability is in between 20 to 40%. So as compared to this molecule, the bioavailability of oral semaglutide is only 0.8%. So half-life is 29 to 48 hours. So once daily administration is possible. It doesn't need co-formulation with absorption enhancing agents. So no interaction with food. So good for patients taking other drugs requiring a gap with the food. So again, the newer drugs like amylin, which is co-secreted with insulin. So mechanism of action of amylin is again a peptide which is secreted with insulin from beta cells. So it can increase satiety. It affects the hedonic control of eating. So it can induce satiety by satisfying the hedonic centers in the brain. So we know about pramlintide, which was the first amylin analog, which was FDA approved for the treatment in type 1 as well as type 2 diabetes, for using mealtime insulin alone, or in combination with oral agents such as metformin or sulfonylurea. So considering the pramlintide has got an effect on the body weight, so the effect is not limited to those patients with type 2 or type 1 diabetes. So this effect is actually replicated in the invention of cagrilintide. So it's again another study which is published in Lancet in 2023. It's a phase 2 trial of CagriSema, that is efficacy and safety of co-administered once weekly cagrilintide 2.4 milligram with once weekly semaglutide 2.5 milligram in type 2 diabetes. It was a multi-center randomized double-blind active control phase 2 trial. So where cagrilintide is combined with CagriSema is combined with cagrilintide and semaglutide. So at the end of the study, it is shown that there is a very significant weight reduction with CagriSema, which was superior to the combined weight reduction, which was obtained by cagrilintide as well as semaglutide, cagrilintide and semaglutide. So the weight reduction was 15.6% over a fixed time of 48 weeks. So, surgical versus medical management. Nowadays, it is said that many of the medical therapies, including subcutaneous desipepatide and some of the subcutaneous semaglutide, that is Wegovy, some of them are going to be, the results are going to be comparable with the bariatric surgery over a period of time. And the major limitation of bariatric surgery is that after a point of time, like lifestyle interventions, the patients are going to gain weight with bariatric surgery. So, medical management of obesity is very important, and that actually underscores the importance of medical management of obesity. So, this is actually an approach algorithm where if the patients are meeting the FDA criteria for obesity management with drugs, we should try with lifestyle intervention and cessation of weight-induced medications. And over 3 months, if the patients are losing at least 5% of weight with lifestyle interventions, we can actually try with lifestyle interventions. So if they are actually failing on that, we should consider the age of the patients and the comorbidities that they have. So if the age is more than 65, probably Lira, Sema, and Fendiramine, Topiramate are the safest ones. In age less than 65 and no comorbidities, we can try all medications. There is no contraindications. And in case of some comorbidities, if the patient is having CVD and DM risk, obviously Lira and Orlistat can be tried. And in depression, it's better to avoid semaglutide. And liraglutide can be tried. Naltrexone, bupropion, Orlistat, Fendiramine, Topiramate can be tried. If the patient has history of MTC, medullary thyroid carcinoma, or pancreatitis, we cannot give GLP-1 analogs. And again, we have only animals data regarding the occurrence of MTC. We don't have human data. Still, FDA says with a history of family history or personal history of MTC, it's always better to differ from the use of GLP-1 agonists. So, naltrexone, bupropion, or early starter of indiramine, topiramate, we can probably try. Nafil, again, liraglutide and semaglutide has got some effect. So their effects are in mast cell. Actually, it is said to be due to reduced weight rather than they are not having a de novo antifibrotic effect over the same, but they can actually significantly bring down the weight, which can actually result in the reversal of the initial stages of mast cell. So probably that may be the thing. Then obstructive sleep apnea, liraglutide, orlistat, phendiramine, topiramate can be tried. Opioid use or history of seizures, we cannot use opioid agonists. So liraglutide, orlistat, phendiramine, topiramate, or semaglutide can be tried. So in cardiac conditions like uncontrolled tachycardia or hypertension, liraglutide, orlistat, and semaglutide can be tried. So the subcutaneous semaglutide molecule is still not available in India. That is the major limitations. So with that, I'm actually winding my presentation. Thank you.
Thank you, Dr. Vishnu. A great presentation, and you've been able to put into perspective in a short period of time the entire spectrum of recent advances in obesity management. Good evening to you from Vinayak Sharma ji, also from Bimla Kapoor madam. Ramchandra Joshi ji reminds us that Dr. K.K. Agarwal saved millions of lives through not only, maybe not directly, but through all the people whom he taught during COVID. And
Mm.
unfortunately, he succumbed to COVID himself.
That's
Good evening to you. Yeah, also from Dr. Pradeep Rawal, who is from Ujjain in Madhya Pradesh. And there are multiple questions. One question coming is, sir, does everyone have the same response? When you say with a particular drug, 10% weight loss or 30% weight loss, will all of us have the same response if we take the same medicine?
no, that is actually the main thing which we have to counsel the patients very well before starting a treatment, because the response is always heterogeneous. So I have some patients who are actually losing pretty much. With I am actually giving Rybelsus in pre-diabetes along with in pre-diabetes along with obesity. So such patients I am actually getting very good weight loss in some fraction of the patients. Some are actually not losing that much. Some patients are actually losing with the side effects. Some are actually developing intractable vomiting. Some are developing diarrhea. I don't know exactly the mechanism behind the weight loss also in such patients. Some patients are actually gaining some weight. I had a patient who actually gained half kg with Rybelsus and he came back, but his diet thing was wrong actually. So it is
Hmm.
very important to ensure that the patient is taking a hypercaloric diet along with a fixed aerobic exercise or a weight losing regimen exercise along with these medications. So
Hmm.
that is the thing. We can actually try those medications again with the Rybelsus that we have or oral semaglutide that we have are in a concentration of 3 milligram, 7 milligram, and 14 milligram. And the main trial, which actually demonstrated a significant difference with the placebo, was the Oasis trial, where they actually tried with 25 milligram and 50 milligram. So I actually went through many literature where they say that Indian patients are having more side effects, gastric side effects, as compared to their Western counterparts. So where they are having more vomiting tendency, where they are having more diarrhea, more gastric side effects, as compared to their Western counterparts. So still, we have to tell all our patients that the effects are going to be heterogeneous. So it is ideal to give a patient a trial of 2 weeks or 3 weeks and see how they respond and if they can tolerate the drug or not. That is very important.
So, how do we minimize these side effects, Dr. Vishnu? Many people take these drugs off label or as per label. So,
Yes.
and let's talk about it in different buckets. So, our topic now is how do we minimize or mitigate the side effects of anti obesity therapy, which is available in India. So, first
Um,
part would be how do we modify our diet? And then the second part would be how do we modify maybe the timing of administration of these drugs for a short period of time. Third would be what are the other pharmacological drugs that we can add for a short period of time to overcome the nausea, vomiting. So, one by one. So, first is how do we change the diet pattern, the diet quantity, and the diet quality so as to reduce the side effects?
So diet pattern actually we can actually change it into a three major meals and two minor meals with a hypocaloricity which is maintained in the diet. So this calorie we should actually give a fixed calorie deficit for the patient so as the patient's weight loss can be enhanced over a period of time. And just we can ask the patient to take the tablet if in case of ribelsis actually usually it has to be taken in the empty stomach in the morning at least half an hour before the first food. So the patient has to take the tablet in half glass of water in an empty stomach. So
Mhm.
patient can have nausea, vomiting, and again diarrhea is one of the common side effects. So patient can avoid. There are some measures which are non-pharmacological, and there are some measures which are pharmacological for avoiding these side effects. So our aim is to avoid or treat the side effects and go with the drug. So that is a strategy which I use. So I usually ask my patients to avoid some of the nauseous stimuli. They can actually use mint or they can use lemon and all to avoid the nausea and all. So the nauseous and strong smell they can actually avoid in the morning hours. So if the patients are still developing nausea and they are actually developing some sort of intractable vomiting and all, I'm actually giving them pharmacological therapy in the form of domperidone or pantoprazole just before the food. So if they are actually developing interacting diarrhea over 2 to 3 days, in fact, probiotics can help them. If we are actually giving probiotics for a short course of time, some of them are actually coming up with good results, and we can actually continue these drugs over a time. So the aim is to continue the drug for a fixed period of time and see the response.
So point well taken. So in case you have side effects, rest assured they will be transient, they will be self-limiting, and that is what the doctor should explain to the patient as well. ये जो हम GLP-1 आर यूज करते हैं, यदि इनसे कोई साइड इफेक्ट आया तो कुछ ही दिन के लिए रहेगा, बट उन दिनों के लिए फॉर दोज डेज व्हाट कैन यू डू? एक तो दवा का टाइम चेंज कर दें. फॉर अ कपल ऑफ डेज यू माइट वांट टू टेक बिफोर लंच और बिफोर डिनर फॉर अ फ्यू डेज. This is when you start the therapy or when you intensify, when you increase the dose. Secondly, जैसे डॉक्टर साहब ने कहा, 3+3 और 3+2 मील पैटर्न जिसमें स्मॉल फ्रीक्वेंट मील्स होते हैं, एंड उसके साथ भी साइड इफेक्ट्स कम होते हैं. अगर डायरिया हो तो प्रोबायोटिक्स या दही, यू कैन टेक कर्ड और योगर्ट ऑल्सो 100 ग्राम्स. और एक और चीज जो डॉक्टर साहब ने कही, यू कैन यूज ड्रग्स टू प्रिवेंट वॉमिटिंग, but apart from that you can use what we call comfort foods. So comfort food might be ginger candy, it might be a toffee, it might be a spice, like you can keep maybe a clove or maybe cardamom in your mouth. So लौंग या इलायची रख सकते हैं मुंह में. That's a comfort food, and each person will have their own different comfort foods based upon where they live and what their likes and dislikes.
That's true.
There's a question, Dr. Vishnu, from I am the expert. So, hi, expert. It's good to be with you. And the expert is a very good role model for us because he's been losing weight very well. So, he has just completed 30 days of 3 milligrams oral semaglutide and is starting 7 milligram from tomorrow. So, 3 cheers. And the question is, I also take thyroxine 75 microgram, not milligram. So, first question that they're asking is it safe? And the second question is, what time do I take semaglutide? What time do I take Tylenol or thyroxine?
We can actually do this in two things. Either actually you can actually take semaglutide first, and after that, 30 to 45 minutes after that, you can take Tylenol, and after which, with a gap of 45 to 1 hour, you can take the breakfast. Or you can actually shift your Rybelsus tablet to before noon meal. If the patient is not taking anything before the noon, up to 15 minutes or 20 minutes back, the patient can take 30 minutes back, patient can take Rybelsus and you can manage it in that way.
Don't take them together, though there should be no clinical impact. But if you take oral semaglutide and thyroxine together, you might end up increasing the absorption of thyroxine, which will bring down your TSH. Uh, and another option is to take thyroxine late at night, just before going to bed, 2-3 hours after dinner, and just before you switch off the light. So that would be another option. And it is very safe. And thanks, I am the expert for raising this point. Dr. Vipin Sharma, who is a senior physician from Himachal Pradesh, has joined us, and he says that now obesity has become a major public health problem. So, these drugs alone, will they be able to handle the public health challenge, or do we have to do something else apart from taking medicines?
So along from with medicines, it's very important to maintain the lifestyle things, lifestyle things. So these anti-obesity drugs can very well actually, in majority of the population, it can bring down the weight. So for maintaining that weight loss, lifestyle interventions, the role of lifestyle interventions are in maintaining a proper weight rather than reducing it. So if the patient is getting into a good weight, he can maintain that weight with proper lifestyle changes that can be continued throughout his weight. So it can be in the form of aerobic exercise, anaerobic exercise, yoga. You can actually try to be in hypocaloric diet, non-vegetarian diet. So anything can be tried. So it should be hypocaloric and should be healthy, which should be combined with all these drugs. That is very important, I
So
think.
these medical advances are very useful and they are helping us. You saw the data shared by Dr. Radhakrishnan, but along with that, you do need to change your behavior, your diet, and your exercise or physical activity regimen.
That's
It's
very
been
important.
great. It's been great having you with us, Dr. Vishnu. We also have with us Faraz. Faraz is backstage and he looks after the IJCP platform, the KK MedTalks platform, along with his colleagues. So, Faraz, anything new that you learned today from Dr. Vishnu?
Thank you so much, sir, once again for this opportunity. And I found that something new in today's session, that like the topic was recent medical advances in obesity, right, sir? As we have discussed lots of things, the role of lifestyle, the role of technology in managing obesity. The thing is that medical advances, as there is a nature's law, sir. When we were in 12th, we have learned that we have to adapt as per the situation, like survival of the fittest, right, said Darwin's theory. So I hope that like medical also advances with time to time, so that the diseases are also increasing. Obesity has now become one of the disease, not only for all people, like it has for general population also, right, sir? I hope after watching this session, it will be very much impactful. They will also learn, when the patients are educated, it's easy to for the doctors also to treat, right, sir? I hope, sir, when they will go from this session, they are going to learn many medical terms and try to overcome and make the things easy for the doctors also.
That's
Yeah,
very
this is
important.
important. Yeah, because then you can have a proper conversation with your doctor. You can speak with them properly. In fact, there is an editorial from around 12 years ago written by Dr. Matthew John from Trivandrum. Together, what we said at that time, and in Hindi, उस time सरस्वती बैठी होंगी हमारी जुबान पे या हमारे पेन पे, हमारी कलम पे, on our pen.
Mm.
What we have written is that the endocrinologist of the future will be a bariatric physician. And this we
Mm.
wrote more than a decade ago. But now I feel even that statement was wrong. The medical professional and the healthcare professional of today and tomorrow will be a bariatric care professional. So
Mm.
it's
That's
not
true.
only endocrinologists, it's everyone who has to take care of obesity. And like Faraz rightly mentioned, this is the law of nature. You have to adapt, otherwise you're going to perish. So we all
That's
have
true.
to adapt together and we have to fight this epidemic. So
That's
thanks
true.
Faraz for giving a new perspective, a new twist to all this.
Thanks,
Welcome, sir.
thanks
I
for
would
the
like to,
opportunity.
yes, sir. I would
Faraz
like
is
to
a,
add one more thing. Like
yeah.
surname title is Radha Krishnan. As we know that we celebrate Teachers' Day on the name of that Sri Radha Krishnan only. I sir is also becoming a very good educator also. Like that's I would like
That's
to
a
add
Well,
on
I
this.
will encore. Three cheers. And thank you, Faraz, for a super duper twist. And thank you,
welcome.
Dr. Vishnu, for living up to the Radhakrishnan standards. So, Faraz, if you
Thanks.
done a good work today, can we show a certificate of appreciation to
Sure,
Dr.
sir.
Vishnu?
Sure, sure. Thanks.
So, thank you so much, sir.
Thank you so much.
Thank you for being with us. With this, I'd like to thank everyone for having been part of today's Obesity Med Talks. जैसा कि आप सब जानते हैं हमारा हर सोमवार ये प्रोग्राम होता है और हम ओबेसिटी की बात करते हैं मोटापे की एंड वी कीप ऑन टॉकिंग अबाउट डिफरेंट एस्पेक्ट्स दिस इज अवर वे ऑफ पेइंग होमेज टू डॉक्टर के अग्रवाल सर उनको हम श्रद्धांजलि देते हैं इससे आई एम वेरी श्योर जहाँ पे भी होंगे सर वो हमें देख रहे होंगे और खुश महसूस कर रहे होंगे दैट वी आर ट्राइंग टू स्प्रेड डायबिटीज अवेयरनेस ओबेसिटी अवेयरनेस हेल्थ अवेयरनेस मगर अकेले अवेयरनेस से कुछ नहीं बनना अवेयरनेस के साथ एक्शन चाहिए सो वी नीड टू गो इनटू एक्शन मोड सो एक्चुअली चेंज योर बिहेवियर change your diet and physical active regimen and seek help from your friendly endocrinologist reach out to them and ask them what is the best we can do from a medical perspective with this Faraz thank you Dr. Radhakrishnan thank you shukriya
Thanks.
meherbani in Haryanvi thara bhala ho and jai hind
Jai Hind, sir.